Thank you very much. And happy to share my views from Health Insurance Fund. I'm probably going to take us one step lower from the vision and European level that Jaarika very well introduced, and take us to where our pain points right now are and what are the main hypotheses how to actually get on from here, from the point where we are. And yes, I've been in Health Insurance Fund for almost 5.5 years now. I've been leading innovation projects, trying to get private sector integrated better or find more solutions. Right now, I'm more centered on central product portfolio, and I've also worked in the hospital, so I should have kind of a broad view, and I'm really trying to find solutions how to get us all in the one whole ecosystem, or building one structure where we all have our roles, because each and every one of them is very important to get this going. Okay, and my main message today is that we have an urgent need to increase the value that we get from healthcare IT investments, or the money that we have in IT right now. As you all know, the situation or the political situation today is so that we can't end each problem with the solution. We need more money. We actually need more creativity in find ways how to make the system work so that the money that we have creates more value. I actually put in a prompt in the AI that there will be no more money for a short period. I would say it would be unrealistic to hope for much more money in the next 3 to 5 years. But the good message here is that there is money in the market. We just need to figure out how to invest it so it creates more value. Very shortly about the background, rapidly growing healthcare needs. As you can see here, 5 years old population pyramid. This is already one step up. I am in the age where we're the first ones who are gonna be holding up the upper section. And this pyramid shows that the healthcare needs are definitely growing with the age of the population. The workforce growth in healthcare is definitely or is far from being in line with the needs. Then, as I said, state primary focus is understandably right now defense, which means, which is the reason why we can't hope for just more money in the next years to come. And now we come to the solutions part, where digital solutions, central or private, all together actually have great potential to provide healthcare professionals more time to be able to help increase the quality of care or the quantity, or they can take more patients. And the patients can be enabled more information and services to help themselves, to be actually more taking part in their care process and unburdening the system this way. Okay, so much of the why. Where are we today? So, as I said, the money that we have in the system today needs to make or create more value. Today, there's basically 3 big blocks, and I'm here. It's Health Insurance Fund resources, how they're divided in different parts of the sector. So we have hospital IT systems and primary care IT systems, and then we have central solutions. In each of the sectors, primary care and hospital IT systems, there are 4 to 5 main providers or IT vendors, which all can have like sub-products, etc. And hospital IT systems part is quite on top, like we had a survey last year. But primary care, this includes on top of primary care practitioners, IT vendors, it's also all of the other primary care healthcare providers or service providers. So this pot is more versatile. And then about 5 years ago, our central health information system is more than 10 years old already. At first, it was, as Margus in the beginning said, only just a document-based archive. We've been moving in the past 5 years more and more towards the vision that we need real-time data, we need some central services. We have national portals. Our health portal has just recently been renewed. We're working on the specialist portal right now, where there's a data view. We're very well accepted by the clinicians. We do have more and more specific products in the past 5 years, where we've developed them like centrally and moved from local developments to central, but there's still integration burden. And this is how the money today is divided. So that the principle that when we develop like centrally, it will save us money and time developing locally. That has been actually tested, but it still hasn't brought us all the wins that we were looking for. For example, speeding up the time to market or lowering the development costs as much as we want it, because the integrations are really are still a headache. So the main questions right now, this is one of the illustrations again from the problem side, that all the changes in the central products or the new product development needs to be done basically 8 times when we talk about how many vendors we have. And also secondary use of data, this is what Jaarika very well explained already. Data comes in different forms and quality from different vendors, because every vendor develops their own data standards, basically. And then we need to clean, restructure the data. Or actually, what's a pity, we very often burdened the healthcare providers with double reporting for secondary data collection, so we could do some smarter decisions depending on that. So to take it all together, we still have very unacceptably long time to market. Our first products that we tried to do centrally, first actually FHIR product, medication list took about, or is going to be live probably in about a month, but it took almost 3 years of actually getting there. Understandably, it's the beginning of doing the things differently, but today still the time to market is not there. User satisfaction. We do have some good examples. For example, our health portal has very high user satisfaction rates today. The central portal, we've managed to close some of the hospital self-portals with doing that. But for example, we did a survey last month for general practitioners' IT solutions, and the general practitioners said that the net promoter score for their solution today is -25. If you know the scale, -100 to 100, it's horrible. And the problems are not the lacking functionalities. The problems are like it takes too much time to load, or I can't zoom in and see what's going on there. So the situation, for example, on the general practitioners market today, the way that we've done or organized the market isn't actually enough. We need to do something there. Big investment compared to the value added. Here I'm going to talk about, for example, like a standard change in a e-booking system, central e-booking system. All the 8 vendors need to do their change there. And we're only changing, for example, adding one small service that can be paid for. So it's basically such a small change, such a small value added to the customer, but the 6 to 12 months of communicating change planning that needs to take place for that small change to happen is enormous. It can't be like just say that that's the way we do it. We need to have a year of planning before we can do something very small. Secondary use, Jaarika already talked about. The clinical data is not whole. We have conflicting evidence from, for example, Health Insurance Fund and Health Information System, etc. And cybersecurity is definitely not strong enough. And today, here, most of the problem is actually we don't have enough workforce or competent workforce for cybersecurity for all the institutions that actually have to secure their data and IT solutions. So here we also need solutions. I would say these 5 are the biggest challenges right now that we as a whole, as a system, are facing, and we need to face them together. So I said I'm not only going to talk about problems, I'm going to give you some hypotheses for today's discussions. I say that the health IT systems must form a whole. And I'm not talking about centralizing everything. I'm not talking about the government providing everything. I'm saying that we need to work in the same environment of rules, of architecture. And each and every one of us still has a huge part to play. And I would say even the private sector's part can grow in this environment. But we need to have common rules for coexisting or co-creating value. I've talked about the first one a couple of times already. So develop the same functionality once, save money for more functionalities. That would mean the same functionality is used wider. So basically, we have a solution for solving one problem, but this is used all over the country. That would hypothetically save us more money for creating more functionalities that we're really, really, really lacking on the market. Then the second hypothesis, we must reuse building blocks in all developments. What are those building blocks? For example, patient administrative data service, healthcare provider administrative data service, probably a diagnosis service, like that can be used in each and every one of the business value creating services, for example, medication chart or medication management or observations, etc. But those things like patient information, healthcare professional information, they still stay the same. And they could actually be used also by the private sector solutions when they're well in place and can be used. That could save time in developing those new functionalities. And the third one is using predefined clinical data models for all solutions. That means that the standardization process is we use that standardized data already in developing all the new modules and functionalities. So basically, when we have decided, like nationally, we're going to use this data standard model for that purpose and this one for that purpose, and every one of the private sector vendors also uses those standards to create their own products, which means that they don't need to invent their standards every time. Like how do they show blood pressure, or how do they structureize height or weight of the patient. And that is the enabler for secondary use as well. To do all what Jaarika described, I would say the enabler is here for the AI products, for the scientific work, for smarter leadership decisions, leading our healthcare decisions. That is the key here. And just a very quick insight in, like, this is not an architect picture. It is just a visualization of the three hypotheses, meaning that we would, today we have those as it's called there, local components, very many of them, because everyone has it, and it goes through all 3 levels. So we have very many monolithic systems on the market that create all the value that is here. Here's the interface level, here's the solution level or application level, and then there's the data level. And basically, my hypothesis would say that the shared data standards and platform, it can be negotiated like where the physical data stands. Is it at the local provider's place or centrally, or how it is most, it makes most sense also cybersecurity-wise where to hold it. But the standards give us, enable us to exchange the data very quickly. Then all the, actually here, some of the examples of the applications go from more administrative or wider used ones to narrower ones, and these can be reused in creating each and every one of the next applications. There can be other products. All that we today say is like a private sector product actually is also here. And here it doesn't mean that we program anything centrally. It means that we know what we need and we pay for it once, just for the one functionality. But we can buy from private sector the whole product. We can buy programming. It can be done different ways. So how the market shapes itself, it will, I can't say right now. But what I'm saying is that I believe that those common building blocks would give us more flexibility and more possibilities to actually integrate them. And also, if we want social system to see something here, we can buy the blocks, we can open and close any of those functionalities. And interfaces level as well, it's not limited, but the question is how many makes it sense, how many interfaces it makes sense for the same patient group to have. So we can end up with only one primary care interface, we can end up with a couple. It makes these decisions need to be made on the way. So that hypothesis is spreading the health IT market into smaller components, but they need to make value by themselves separately or by combined. How many providers we would have, how the market would shape around it is different. But I actually believe that using the central standards, these products would be more capable of export also, because all the markets are actually moving towards the same goals, but in different speed. I actually think for us all, centrally and also private sector, this way to go, I think, might help us further, help us stay on top, as Jaarika said, and lead the way. The other way is also we can always sit down and wait for the way to become and then lag behind. So there are options. I'm looking forward to today's discussions. I'm happy to answer any questions. Happy to be here.
We have quite a few minutes for questions, so please be bold. Thank you. Yes, we have a question here.
Thank you. Very interesting. About specialist portal, you said that it's well received. But what type of functionalities?
We had the vision of specialist portal. It was about 3 years ago. Today we're launching first products on top. For example, the first one is going to be the data viewer that we're going to bring there. So all the functionalities to get them faster to market, we're going to put there. But yeah, the medication management function is the first one of the real functions that will be there, hopefully by the end of this half year.
Okay, thank you.
So it's still young.
Any more questions? Yep.
Thank you for the presentation. I have a question regarding this kind of ecosystem or environment of the IT system. Somehow the insurance fund is now in a role of building this environment. is that, I'd say, is it the way it should be, or how do you see it? I understand that in Estonia we have one main insurance fund provider, and am I right that it is in your interest to build that?
As I began my presentation with, we're behind the numbers, right? So our question naturally is, where does the money go? Do we spend it smartly? Our mission actually in Health Insurance Fund is that spread the funds, the united funds that we have, smart. And that is what has driven us into IT, because we see a huge potential here. And in the past 5 years, we've taken like most of the e-health product leadership to us. Actually, TEHIK is our greatest partner here. We have like a joint team. But yeah, the leadership part, because there are no more funds for development. So we actually provide the funds because we want to see how it helps us with the problem of the growing population age, etc. We actually see a way out here, or at least some of it.
Yes, we have a question there.
So, thank you so much. One quick question and a longer question. One question is, have you looked at also the balance sheets and of these companies who provide them, and matched your cost of, let's say, 50 million to the company's revenues in these specific segments? I did a quick search and I got a bit different numbers, so maybe you want to look at from two sides. Maybe a part of this, let's say, 50 million family doctors goes actually to salaries of family doctors or nurses, and they pay a bit less to the developers.
It can definitely be. And family doctors wise, it's, as I said, it's not only the general practitioners, but it's all of the rest of primary sector as well. And it can be, actually, and I'm talking from the side of us, if they spend this money somewhere else, then it means for us it's the IT cost. So that is the money that we can use to create more value. That is actually what needs to be definitely balanced. But our mission is to make sure that what they're supposed to get for that money, that they get. But now we know that they don't. So we can restructure how we put out the funds.
Okay, so and the second question is, so right now we have a model where there are some like patient portal, specialist portal developed centrally, then we have these prior providers, and then there is this vision which has basically semi-front-end modules that should connect via an API to like a central database. So what could be the timeline, and is there any plan how this shift actually could happen towards this, well, I would say like international unprecedented approach to managing a healthcare IT market?
I would say actually what I hope today to hear more about is how others have also done it, how those standards have been used. We need to make that strategy. We don't have it yet. The plan is to have that strategy in place by the end of summer, how to move, and we need to define like what goals to take, because all of that can't be achieved as like a big bang. This won't happen. But how to make it into smaller steps that are achievable, we need to consider, because I would say we don't have many other ways, because right now doing the small steps won't take us far. As I said, for example, changing a standard takes us a year of planning and the resources still go in there. We need to have a little bit longer plan in place.
Thank you. Yeah, definitely let's go I'm moderating the last session. We can go deeper into these 8 times numbers and discuss it with the team, but thank you so much.
Thank you.
Thank you, Jaarika. Yes, as Priit said, Jaarika will join us for the panel afterwards as well. So, thank you.